Well, thank you very much. I didn't understand a word you said, but it sounded like it was very nice.
It was
Thank
good.
you. No, thank you. But all seriousness, thank you for the lovely invitation. It's been a spectacular meeting. The energy in the room, in the halls has been phenomenal. The science has been first rate. And I just really want to thank you for the kind invitation. I do want to say, too, I've been very fortunate to be editor-in-chief of Circulation Cardiovascular Imaging for now 6 years. The strength of the journal are the associate editors. They do the bulk of the work. They're the ones that are making the major decisions. And we are very fortunate to have Octavio Marchio making many of those decisions. So thank you both. And if you get a rejection in CT or MR, you know who to talk to. But so let's talk a bit about nuclear perspectives. We've heard wonderful talks about echo, MR, and overall, I think the message to start out is these are multimodality approaches. No one test is going to answer the questions that you want. Just these are my disclosures, nothing of real significance here. And what I'm going to do is I've listed some of the same infiltrative cardiomyopathies Octavio did. I'm only going to talk about two, amyloidosis and sarcoidosis, primarily because they're the ones that nuclear has the most impact on. Fabre's a little bit, but I'm just not going to have time to get to that. So let's just start with a case. You've already heard about the disease, the background of the disease, so I'm not going to go through that. But this is a patient that we just had not too long ago that I saw in clinic, that 72-year-old black male with heart failure, diabetes, history of colon cancer, had a non-obstructive, coronary angiogram, mild to moderate disease, but pretty significant LV dysfunction. Let's see if we get this. The echo, as you've seen over and over, has this diffuse hypertrophy. You see you have the apical sparing, which we've learned is not necessarily pathognomonic for cardiac sarcoidosis. But because of all this, there is a concern for cardiac sarcoidosis, so they referred to our clinic for a sodium PYP scan, and this is what you see here. And these are, I know they're not available to everyone here, but these are very simple scans to do. Let me give you an idea. We inject the tracer, we have the patient sit and read a magazine for a couple hours, we image for 10 minutes, we get the planar image you see here, we then do another 10-minute SPECT, which I'll talk about here, and we're done. So it's actually a pretty easy test to do. The image on the left is a planar image, and we're looking for increased uptake in the myocardium, and it's a very straightforward scoring system. Is the uptake 0? Is it 1, 2, or 3? 1 is less than bone, 2 is equal to bone, 3rd is greater than bone, with the bone being ribs. In this case, this is a 3. The SPECT we do because we're worried about blood pool being the cause of the signal on the planar image. Here you can see on the rotating MIP, in fact, it looks like it's the myocardium, and the SPECT image here, which shows very nicely that this is the CT on top, here's the PET, but here you can see the uptake in the myocardium. And as we'll talk about, this is pretty classic for ATTR cardiac amyloidosis. And the patient underwent biopsy anyway, and that was what they found. I will say this test is actually replacing biopsy at our institution when it is this strong of a finding. So you've heard again, with cardiac amyloid, we're really splitting into two broad classes, the light chain disease, and then we have the TTR disease. And it's pretty critical to make a distinction because your treatments are totally different. Your advice is totally different as it relates to genetic testing and so on. So it's pretty important that we can do this. And we can tell which is which, not just that you have the disease or not. So if we look at cardiac amyloid, where can nuclear help us? These are all the different tests that are available in the nuclear medicine armamentarium to look at cardiac amyloid. And I will say that only the bone agents are the ones that show the most success. The various beta amyloid agents that are now used for brain, and I'll show some data on this, can tell us maybe about AL, but the data still isn't very strong. Sodium fluoride has not been shown to be very strong. As I'll mention to you, measuring perfusion may be important. We've already heard about that earlier today. But again, to drive home the point, these studies are only useful if you're doing them in the setting of also doing echo and MR. So I showed you, if I have a positive TTR study or pyrophosphate study, I know I've got TTR disease, as we'll talk about in a moment based on the diagnosis. What's the patient's risk and how common is it? Well, this is a study, it was a retrospective study where they looked at roughly 17,000 patients with cancer, and they looked at all comers. And what they found was that, and again, these are patients that are getting bone scanned for their cancer. What did they find? They found that grade 1 disease was present, mild disease was present in 1 out of 50. In those patients who had a concern for cardiac amyloid because of maybe other imaging that we've already heard about, they're now saying this in 9 out of 50 patients. The point being, it's a fairly common disease. And we have to be sensitive to look for it when we have phenotypes that we see on echo or MR or other clinical phenotypes to say we should be taking advantage of this technique. And it just shows that when it is present, particularly the more severe disease, the patient's long-term outcome is much worse. So it does have prognostic significance. This is an algorithm, I think we've already seen it. Bottom line is that pyrophosphate scanning is critical in this paradigm, but you first, at least we believe, should be doing light chain analysis to exclude AL amyloid. Once that's excluded, then doing a pyrophosphate scan makes sense. If you have a light chain disease, you probably should not be doing the scan. There are new agents coming online. You heard about this agent earlier. It's a pan-amyloid agent. It will be showing up in both AL and TTR. Interestingly, and this is data on the bottom here, if you compare the florpiridaz or florbetapir, which is one agent, with the newer agent, you don't see any difference. It doesn't do any better for AL. It does much better for TTR. So I'm not sure whether this agent is going to help us much because florbetapir lights up in TTR as well. So I'm not sure where this is going to help us. It obviously discriminates well between that and LVH patients, which is what we'd like to see, but we're going to see more about this agent, but because of here, it's not doing a better job, I'm not sure where it's going to play out long term. I want to close in the amyloid space about talking about blood flow. This is the first study done using PET back in 2014 by Shamil or Dorbala, who looked at LVH patients versus those with amyloid and found that rest flow was lower, stress flow was lower, and flow reserves were lower in those patients with amyloid versus those with LVH, where we know have flow reserve abnormalities. This has now been shown more and more, particularly in the MR literature, has prognostic implications. This is just one example here where they showed very nicely that in those patients who had an impairment in blood flow, particularly in the left ventricle compared to the right, they did much worse than those patients who didn't have the impairment. So clearly there's prognostic implications there. I don't know how much they help you diagnostically, except that it fits in the whole paradigm, but prognostically it may be very important once you know a patient has cardiac amyloid. So what are the take-home points on this? Again, bone agents work great. There are false positives because of AL amyloid. We've heard about this. You need serum light chains. False negatives can occur in certain gene variants, so you've got to keep that in mind. It has prognostic implications, has downstream effects when present, as I mentioned on blood flow. I didn't get into monitoring of therapy because as of now, the bone agents don't help you. We'll have to see with the newer agents, because as of right now, we just don't know. And again, multimodality imaging is critical. All right, so let's jump to sarcoid. I got 6 minutes here. I show this slide, I really like it because it tells us the different stages of an inflammatory process, which sarcoid is. And it tells you that when you start at the earlier phases, what are you going to see with PET and MR? And then as you get to the more significant phases, what are you going to see? In the later stages, what are you going to see? And it has relevance then as we think about these signals that we have with imaging, where are we in the stage of disease? And that means that certain approaches may be more helpful in answering questions relevant to the presence of disease and its stage of disease. Again, another case, 51-year-old guy came in with lung masses, lymphadenopathy, biopsy-proven sarcoidosis. Here's a CT kind of showing all that. TT on the outside showed LVH, so they're wondering, is this heart involved? We do SPECT imaging because we're looking for areas of reduced blood flow, because if we see that with increased FDG, that might be a higher risk. Here's a PET scan. The rotating MIP shows the entire chest lighting up with sarcoid. You see a small area right here in the basal septum and right here, consistent with cardiac involvement. So this clearly is a case of cardiac sarcoid. We feel more confident when we see extracardiac sarcoid, but a pretty classic case. He was started on an immunosuppressive therapy, followed for a few months. There was a question of how's he doing. There was a concern, is it coming back? And the answer is not. Here's the rotating MIP. There's no increased FDG. And you see very nicely, no FDG uptake. So the inflammatory component of the sarcoid has been mitigated, at least at this stage. So we use it for therapy tracking as well. But there is a complementary nature to PET and MR. Octavio showed you this very nicely about these various patterns that can show up. The point is, and I'm saying it a little more differently, is that when you have an MR, it might say, gee, I think I have sarcoid, they got the pattern. If I had the PET, it helps me reclassify people in the higher and lower classes, because those people with LGE and high inflammation are really at high risk, versus those that with no inflammation would be at lower risk. So the two together really help you in the classification of the disease. The other point I want to make from the same group is if you just focus on this slide, what you see is that the causes, what they did here is interesting, I should say. These are transplant patients. They took their heart, they looked at the hearts that were explanted and said all these patients had a diagnosis of cardiac sarcoid before the transplant. And what you see is that in many cases they did, but in many cases there are other forms of disease. Now clearly when you had classic MR findings, classic nukes findings, they had cardiac sarcoid. But in other cases you didn't, and you saw other forms of myocarditis, such as multifocal lymphocytic cardiomyopathies, the Alvarez cardiomyopathies. We've seen a fair number of arrhythmogenics. So clearly other causes of the inflammation can occur that can look like sarcoid, but they're not sarcoid, and you need to keep that in mind. Risk assessment. How good is the FDG approach for this? It's good, but again, you need to put the two together. The late enhancement we know is a risk modifier. We know inflammation is a risk modifier. It's a recent study from the Sinai group who showed very nicely that when you had positive LGE, positive inflammation with FDG, and if you also look at these patients here who had more LGE, these two together had the most events being mortality, arrhythmia, heart failure, and so on. So when you put the two together, they're the ones where you're going to identify the low and high risk groups. So again, driving home the point that one system, one imaging by itself doesn't necessarily answer the question. However, for therapy, here, I'm a strong proponent that FDG PET, looking at the inflammatory response, is what you're going after. If they've got LGE, the horse is out of the barn. Your therapy is not going to change the LGE that's there. You might prevent further LGE development, but you're not going to get rid of what you got. And here, this is a very nice study where what they did is they looked at treatment groups versus no treatment groups. And what they had was those patients who had FDG alone in red, those that had LGE alone in gray or green, depending on how it looks like on you. Actually, it's gold on your screen, it's green on mine. And whatever the color is, a gray on if you had both. Look what happens with the treatment. When the treatment group, those individuals with LGE, you didn't see any changes. The FDG and the ones that had matched, they're the ones that had the lower amounts of activity, the lower amounts of myocardium involved. Those are the ones that had the treatment responses compared to the no treatment group. So in the case of treatment for sarcoidosis, you need the inflammatory component because that's the one that's modifiable, not the, if you will, functional or the LGE component. Not all patients have FDG, have inflammation. Just show this quickly. These are 3 patients, all the same FDG pattern. And what you can see is that this is a normal pattern. We can see this very often. This patient had sarcoid. This patient actually had myocardial ischemia because of the ischemia FDG goes up. So it says we need new tracers. So very quickly, this is just one tracer we've worked on. It's a tracer that looks like pro-inflammatory macrophages that come from the bone marrow, go to the heart or any other organ that's inflamed, and just showing you that in fact you can have concordant uptake in several patients and discordant uptake. And we're doing more to see if we do a better job of detecting sarcoid using that. The last one I want to show you is we talk about fibrosis a lot. You need to look at active fibrosis, not just fibrosis that's present because you don't know if it's active or permanent. And these are just using a FAPI agent, which looks at fibroblast activation protein. And by doing this, we can look at active fibrosis. And this is just examples, again, in a sarcoid patient where we see this active fibrosis. So these are tracers that are coming online that will probably supplant FDG in the future. So take-home points, FDG PET works great right now for sarcoid. We do it in the fasted state. Again, that's just to decrease the glucose uptake by the heart. Detects new inflammation. I will mention you can have isolated cardiac sarcoid. You don't have to have extra cardiac sarcoid for it to be positive. Need to combine it with MR. I can't think of a study where I wouldn't want both, or a patient where I wouldn't want both done. Context is key. Clinical context as well as imaging context. Has prognostic implications, particularly the CMR, and we can use it to follow therapies. So thank you very much.